can.
Okay, thank you. Welcome to this EURO-NMD webinar organized in collaboration with the European Reference Network for Neurological Disorders and the European Academy of Neurology. Today we are going to talk about novel treatments in hereditary neuropathies, and our guest is Dr. Stojan Peric, a neurologist in the Department of Neuromuscular Disorders of the Neurological Clinic of the University Hospital of Serbia, Central Serbia. Is a teaching assistant at the Faculty of Medicine of the University of Belgrade, and as a thesis in myotonic dystrophy type 1 that he defended in 2014. He's also interested in inherited polyneuropathies, muscular dystrophies, other myopathies, neuromuscular junction diseases, and motor neuron diseases. He has 140 scientific papers and counting. He is member of the editorial board of the Journal of Peripheral Nervous System. He won the Bruce Schoenberg Award of the American Academy of Neurology in 2015. Is a member of the European Academy of Neurology and co-chair of the European Academy of Neurology panel for neuropathies. Is also the co-chair of the Global Myotonic Dystrophy Registry of the hereditary network. Stojan, thank you very much to start with for agreeing to deliver this presentation. And I know for a fact that it's going to be a great webinar. Thank you for agreeing to deliver it.
Thank you very much, Antonio, for this kind introduction. Good afternoon to everyone. I will talk about a very hot topic about novel treatments in hereditary neuropathies. And I must say that these new therapies are appearing actually on monthly basis. So it could be that this presentation is not up to date because new therapies are everywhere. So we will start with my disclosures, but I must say that neither of these disclosures is actually related to this presentation. This is very interesting division of different types of hereditary neuropathies that was given by Alex Rosser from London. And he actually reported that there are pure neuropathies, and there are more than 100 different pure neuropathies, such as Charcot-Marie-Tooth disease or hereditary sensory motor polyneuropathy, but also hereditary sensory and autonomic neuropathies and distal hereditary motor neuropathies. Besides this, we see more than 150 different complex neurological phenotypes with polyneuropathy that can be one of the core features of their disease. And we see polyneuropathies in different ataxias, neurodevelopmental impairment, hereditary spastic paraplegias, and in some other neurological diseases. And sometimes we see neuropathies as a part of a more wider phenotype of complex systemic diseases, including diseases that affect eyes, ears, that are endocrinopathy, cardiomyopathies, hepatopathies, etc. And there is a special group of hereditary neuropathies that can be recurrent. So later I will also talk about some recurrent polyneuropathies here. So when we want to make a diagnosis of polyneuropathy, we are talking about the predominant neurological phenotype that is seen in our patient. Is it poor polyneuropathy or it is a complex polyneuropathy? We are talking about motor or sensory motor polyneuropathies, or about axonal demyelinating polyneuropathies. We are also talking about other features of polyneuropathies, not only neuropathic features, but the features of other organs. And at the end, we should think about if this disease that we are making diagnosis of is treatable or not. If you go to the clinicaltrials.gov site, you can see a number of interventional trials in polyneuropathies, especially hereditary polyneuropathies, with almost 150 different trials. I will start with our patients today. The first patient is Julia. She's 41 and she started with the first symptoms at the age of 5. She has some problems with the tiptoe walking. Later, she developed slowly progressive distal symmetric lower limb muscle weakness and wasting. She has excavated feet and hammer toes, and she had a surgery of hallux tendon at the age of 12 and of Achilles tendon at the age of 18. Later, she also developed slowly progressive distal symmetric upper limb muscle weakness and wasting. And what we know also is that similar symptoms are also present in her family members, in her father, grandmother, and sister. So we see that this disorder is dominant because nerves, these are motor nerves. These nerves are more affected in lower limbs. And if we look at the nerve conduction velocity in motor median nerve, we see it is really slow. It is 17 meters per second, which means that this neuropathy is actually demyelinating polyneuropathy. At the age of 41, at the examination in my office, she is not able to stand in one place because she is not stable. She's not able to open a can. She complains of mild hand tremor, and she also has some neuropathic pain, so she's treated with pregabalin that reduces her pain. She's a graphical designer, and she's really afraid if she's not be able to work on computer in the near future, and she's really anxious for the future and if she will be non-ambulatory at some time point. Here you can see her feet and her hands. So if we look at her symptoms and findings in these patients, we can see that this is a pure polyneuropathy, no other neurological or non-neurological features except the features of polyneuropathy. Nerve conduction studies show sensory motor demyelinating polyneuropathy, but still we do not have the final diagnosis and we do not know if this disease is treatable. What we started to do actually is to test for CMT1A because this is the most common type of demyelinating Charcot-Marie-Tooth or Charcot-Marie-Tooth type 1 because around 60% of all patients with demyelinating form of CMT actually have duplication of PMP22. And we confirmed this mutation in our patients, so the diagnosis of CMT1A was made in our patient. And because she was very anxious and she wanted some therapy, you can see here a list of a number of trials that were conducted in the last year since the MT1A. And these are trials with vitamin C, with follistatin, with some hormonal drugs, etc., some vitamins, and they showed no results. Then there were several trials with the gene therapy, and these usually were suspended without a specific explanation. And there is one trial with mesenchymal stem cells in Korea that is ongoing per the information we have, although the site is in Korean, so I cannot read Korean very well. But if we are talking about CMT1A, which is really slowly progressive disease that does not shorten lifespan, we should ask ourselves if gene therapies are actually potentially harmful in these patients, and should we treat all these patients with these complicated therapies that potentially may have some off targets? We do not know. And another important thing, because in CMT1A we have actually a duplication of PMP22, we have too much PMP22. So our aim here is to downregulate PMP22. But there is an allelic disease which is caused by deletion of PMP22 that is called hereditary neuropathy with liability to pressure pulses. So we actually do not know if with this downregulation of PMP22, we can convert our patients with CMT1A into patients with HNPP. There is one interesting approach in treatment of patients with CMT1A. This approach is called pleiotherapy, which means that any molecule can be used for different purposes. So we can look at some molecules that we already have, and maybe some of them can downregulate PMP22. And this company actually tried to develop drug in this way. They screened more than 2,000 different molecules. They selected 72 molecules that are potential downregulator of PMP22. They tested these drugs in a cell culture. They found that 16 are really interesting and that 3 actually drugs in combination can be very good for downregulation in PMP22. And these drugs are naltrexone, baclofen, and sorbitol. So they started to test this in CMT1A rats. And you can see here that these are controls. This is placebo in patients, in rats with CMT1A. And with this drug that is called PHT3003, they achieved 31% reduction of PMP22 messenger RNA. So this was a significant downregulation of PMP22. When they looked at the histopathological findings, they actually found that the diameter of nerve fiber was increased and that the total number of myelinated axons was increased in animals with CMT1A that were treated with PHT3003 in comparison to CMT1A rats that were not treated with this molecule. So this was the reason to try with this drug in humans, and they conducted a phase 2 trial that lasted for 12 months. They tried actually 3 doses of the drug. Low dose was not better than placebo. Medium dose actually showed a kind of stabilization of patients with CMT1A, while high dose actually showed improvement. And because this was measured by ONLS scale, it is showed that around 0.15 point decline is seen on this scale regularly as a part of a natural history of the disease. In these patients treated with this new molecule, we actually saw improvement of 0.3 points, which is clinically significant. So they decided to conduct a phase 3 trial, and in their phase 3 trial that lasted for 12 months, they actually showed improvement in this impairment scale, ONLS scale, that was used here for CMT1A. And also, as you can see here, also improvement in 10 minutes walking test in these patients. So this was really encouraging. But then something bad happened, actually. And what happened is that in a high dose formulation, because this is oral solution, there was a formation of crystals, and actually many patients discontinued the trial. If you look at the high dose group, they started with 113 patients, and at the end they have only 49 patients that finished the trial because there was a formation of crystals in this oral suspension. And actually, this study was deblinded because they knew, and patients and doctors knew who was on the highest dose because of this crystal formation. So this was not good, and EMA and FDA did not approve this drug. So they advised for a new trial, and the new phase 3 trial was conducted. And this trial actually included only a high dose a PHT 3003 in comparison to placebo. There was more than 380 patients and more than 50 sites included, and there was a way how not to produce these crystals, so they were not visible. Primary efficacy endpoint was ONLS. But what happened here actually is that this well-designed phase 3 trial did not show good results as the previous phase 3 trial. And the reason was that patients that were even on placebo actually improved on LS scale. So both patients on placebo and PHT 3003 actually improved. And they concluded that ONLS scale probably is not good scale to measure this short time outcome in these patients, and new scales are actually needed. So the company now is conducting the trial in China, and I'm not aware of the results of this trial. Now I will show you next patient. It is Gordana, and she is 54 years old. She has walking difficulties from the age of 12, and she has slowly progressive distal symmetric lower limb muscle weakness and wasting with excavated feet and hammer toes, later also distal weakness and wasting of upper limb muscles. And in the last several years, actually, she noticed some mild numbness in her feet. And she is a sporadic case in her family, no other family members that are affected with a similar disease. This is her nerve conduction study, and you can see here that both sensory and motor nerves are affected in lower limbs and to a lesser degree in upper limbs. And the conduction velocity of the motor median nerve is 57 meters per second, which means that this is axonal polyneuropathy. At the time of examination, at the age of 54, our patient is unsteady while walking. She has dexterity problems. She has no significant hyposthesia, but she has some paresthesia, as I mentioned. And she lives on farm, and she is really worried because she cannot help her large family. She cannot help her kids with the grandkids, and she is really worried about her future. So what type of neuropathy this patient has? She has pure polyneuropathy because there are no symptoms of other organ involvement. And this polyneuropathy is sensory motor, more motor than sensory, and it is axonal polyneuropathy. So we still do not know what is the final diagnosis and if this disorder is treatable. What we did actually is that we tested for the most common type of axonal polyneuropathy in Serbia, which is HINT1 neuropathy, and she was negative for this. So we tested her on the whole exome sequencing, and we actually had a positive result. We found a homozygous mutation in the SORD gene, and this was a pathogenic mutation. So we made a diagnosis of SORD-D hereditary polyneuropathy. SORD-D polyneuropathy was described for the first time in 2020, and around 1.5% of cases with a Charcot-Marie-Tooth actually had SORD neuropathy, and this percentage is higher in patients with axonal type of Charcot-Marie-Tooth and in patients with distal hereditary motor neuropathy, where it goes up to, let's say, 10%. The mutation that was found in our patient is the most common pathogenic mutation, and it is present in around 1 in 100,000 patients with in general population. And this neuropathy is actually one of the most common recessive axonal hereditary polyneuropathies. What happens in this patient actually? We know that glucose actually is converted to sorbitol by aldose reductase, and sorbitol is converted to fructose by sorbitol dehydrogenase. So in this patient, we have impairment of sorbitol dehydrogenase. So we have increase in sorbitol in nerve cells. Here in this plot C, you can see increased level of sorbitol in patients with SORD neuropathy. And sorbitol is very toxic for peripheral nerves. And how we can stop this toxicity? We can stop production of sorbitol if we introduce aldose reductase inhibitors. And they tried this in experimental animal model of this disease, and they found this therapy a saving therapy. So phase 3 trial was started in humans, and now we have actually results a 1-year trial that use govorestat, which is a type of aldose reductase inhibitors in patients with SORD neuropathy. And the results after 1 year actually show that sorbitol levels are reduced with this therapy in patients with sore neuropathy. CMT high that is used in this trial is the primary outcome measure was also improved. Treatment was well tolerated, and we are waiting probably for a positive results at the age 2 that will be reported next year. This is our next patient. His name is Marco. He's 28. And at the age of 27, he noticed loss of appetite. He lost 10 kilos in 12 months. And later, after 1 year approximately, he noticed hypotension, dizziness, heart palpitations, constipation, and sometimes diarrhea, and also tingling and neuropathic pain in his feet and also in his fingers. And this is his family tree. Our patient is here, and he has the symptoms, but also his father and a number of cousins of his father actually has had the same symptoms as our patient, and they all died approximately at the age of 40, unfortunately. So at the age of 28, at the examination, patient has severe diarrhea, heart palpitations and dizziness, problems with erection, ejaculation. He is complaining of severe fatigue. He's cachectic with stalking glass hypoesthesia and dysesthesia and decreased muscle reflexes. This is his nerve conduction study, and we can see that both sensory and motor nerves are affected, and we have a pronounced decrease in CMAP amplitudes, with the nerve conduction velocity in upper limbs being around 52 meters per second, which means that this is axonal hereditary polyneuropathy. We examined this patient further, and his tilt test was positive for orthostatic hypotension. He has increased heart rate, low blood pressure. On EKG and Holter EKG, we found multiple ventricular extrasystoles and also low voltage. And his heart ultrasound and MRI showed restrictive cardiomyopathy. Here you can see on ultrasound increased biventricular wall thickness in our patient with no dilated ventricles. And on longitudinal strain, we can see that the top of the heart is actually preserved and normal, which is called the cherry on the top sign. This is his heart MRI. We can see increased cardiac wall thickness in his heart, also in this picture. And we administered gadolinium contrast in our patient, and we showed here a homogeneous enhancement of the whole myocardium. Also, we performed technetium scintigraphy, and it showed diffuse intense accumulation of the radiopharmaceutical in the projection of the heart, as you can see here. That is even more pronounced than the accumulation in the bone system. So in our patient, we have a phenotype of a complex polyneuropathy. This is a small fiber polyneuropathy with neuropathic pain and autonomic impairment, and also nerve conduction study. We see that this is axonal sensory motor polyneuropathy, but this patient also has other symptoms of multisystemic involvement, including cardiomyopathy with the cardiac arrhythmias, autonomic impairment, and gastrointestinal impairment. So we were thinking about the diagnosis and possible treatments for this disorder. And we, of course, were thinking about TTR amyloidosis. We tested our patients, we sequenced the gene, and we actually found this pathogenic mutation in a heterozygous state, because this is autosomal dominant disorder. So we actually made diagnosis of hereditary TTR amyloidosis in our patients. How to treat TTR amyloidosis? We have several approaches. We know that TTR actually is produced in liver, so liver transplantation may be a therapy for some patients, but we now also have some genetic silencers that actually silence the production of TTR. These can be small interfering RNA or antisense oligonucleotides. Another approach is to stabilize TTR tetramers with tafamidis, diflunisal, or tolcapone, or we can talk, let's say, about elimination of deposits with some drugs. The first drug that was actually approved for TTR amyloidosis is tafamidis, 20 milligrams oral, and this is a stabilizer of tetramers of TTR. Actually, the primary outcome in this trial in the intended to treat population actually failed. So there was no difference, as you can see here, between tafamidis and placebo, but some other secondary outcome measures actually showed positive effects. And that was the reason that that tafamidis was labeled for TTR amyloidosis stage 1 in Europe, but this drug was not approved by FDA in the United States. Later post hoc analysis actually showed that this drug is the most efficacious in patients that are with valin 30 methionine Portuguese mutation, and when the treatment is started very early during the disease course. This is another trial that was conducted 6 years ago, and higher dose of tafamidis was used, 61 milligram orally. And in this trial, they included patients with both cardiomyopathy, that is hereditary, and wild-type TTR amyloid cardiomyopathy. And they found really positive results with a reduction in mortality, in hospitalizations due to cardiac diseases, and they showed some also improvements regarding the polyneuropathy in these patients, for example, 6-minute walking test and improvement in quality of life in these patients. So tafamidis 61 milligram actually is approved to treat hereditary and wild-type amyloid TTR cardiomyopathy, both by FDA and EMA. Also, we have some other stabilizers of tetramers, and the approach of CMT1A, actually they use them all molecules to try to stabilize TTR tetramers. And they use this diflunisal, that is non-steroid anti-inflammatory drug. Results were positive regarding the primary outcomes, but there were some safety concerns regarding renal function and bleeding. So this drug actually, at the moment, diflunisal, is only off-label used to treat TTR amyloidosis. Another drug that is interesting is tolcapone, and tolcapone is used for the treatment of Parkinson's disease, but here the drug was repurposed to stabilize TTR tetramers. And actually, it showed some positive results. Further studies should be conducted. But what is really nice about this drug is that tolcapone can pass the blood-brain barrier, so it can be probably used in patients that have a central amyloidosis like leptomeningeal amyloidosis and eye amyloidosis. So this is potentially a very useful approach in this subgroup of patients. The new drug that is another stabilizer of tetramer is acoramidis. The results were reported this year, actually, 2024. This was a phase 3 trial with 632 patients with cardiomyopathy, hereditary or wild-type transthyretin cardiomyopathy, and they show positive results regarding the primary outcome that included death from any cause, cardiovascular-related hospitalization, change in pro-BNP, and in 6-minute walking test. And we expect the decision of the FDA during this month. I today checked, and still we do not have actually a final decision, but in November we will have it, and we will have the decision of EMA regarding this drug for treatment of amyloidosis during 2025. Besides these approaches where we stabilize tetramers, we also can decrease the production of transthyretin, and liver transplantation is one of the approaches that started to use in 1990s. It was not tested in clinical trials, but it seems it can be beneficial in patients with early onset Portuguese type amyloidosis. Besides this, we have some new therapies that are doing actually a silencing of the production of TTR. The approaches are small interfering RNA that interacts with the TTR messenger RNA and actually degrade this. And these drugs are patisiran and vutrisiran, or you can use antisense oligonucleotides instead of small interfering RNA, like inotersen or eplontersen. And there are some tries to try with a true gene therapy, such as the CRISPR-Cas technology. Patisiran, as I already mentioned, is a small interfering RNA that interacts actually with a messenger RNA for TTR, and it actually degrades this molecule. Patisiran is used intravenously every 3 weeks, and the trial actually showed very, very good reduction of the serum TTR for more than 80%, as you can see in this graph. And also, neuropathic impairment scale actually improved in patients treated with patisiran. Quality of life of these patients improved. So really positive effects with patisiran were seen. And FDA approved patisiran for treatment of hereditary amyloid transthyretin polyneuropathy, and also EMA approved this. But this drug is still not approved for the treatment of TTR cardiomyopathy. Side effects that are the most common with this drug are peripheral edema and infusion-related reactions. Another generation of small interfering RNA that is used for the treatment of TTR amyloidosis is vutrisiran, and vutrisiran is subcutaneously administered, which is better than intravenous infusions with patisiran. This is more easy for our patients, and in this Helios trial, it was actually shown that vutrisiran is not inferior to patisiran. It can reduce the levels of TTR in serum as good as patisiran, and the effects on neuropathy impairment scale on the ability of the patients is pretty much similar. So vutrisiran is also approved for the treatment of hereditary transthyretin polyneuropathy in Europe and also in the United States. As I already mentioned, another approach is to use molecules that are called antisense oligonucleotides, and in this way to silence the production of TTR. And with inotersen, that is subcutaneous drug that is used once weekly, actually reduction of levels of TTR in serum was significant. It was reduced up to 80%, and improvement on neuropathy impairment scale and quality of life was clear. So this drug is also approved for the treatment of TTR amyloidosis, hereditary type, both in the United States and in Europe. But with this drug, we should be careful about some side effects, such as glomerulonephritis, tubulointerstitial nephritis, thrombocytopenia, and in some patients, maybe intracranial hemorrhage. Another generation of the similar drug, antisense oligonucleotides, is actually eplontersen, that is subcutaneous self-injection that is used once in 4 weeks. And eplontersen actually showed very good results in the reduction of the level of TTR in plasma, and also improvement in the neuropathy measures. And this drug is also approved by FDA and EMA to treat amyloidosis. And finally, the last approach is a true gene therapy, CRISPR-Cas technology, that was tested so far in only 6 patients. And we expect some larger trial to see the results of this one-shot therapy that can save the phenotype in patients with a TTR hereditary amyloidosis. So as you can see, in the last 10 years, we have a lot of new therapies for previously untreatable disease, which is TTR amyloidosis. And we should think about if our patients maybe have cardiomyopathy or polyneuropathy or both of these, but we still do not know when should we start the treatment, which treatment we should start. Should we maybe combine different use this?
Sorry, Stoyan, we had a large gap. Would you mind going back to the last slide and repeating what you were saying about when to start the treatment onwards? Okay, thank you.
Okay. It is really complicated to say because actually we do not have guidelines when should we start treatment. We do know that we do not treat patients that are asymptomatic so far. We do not have evidence for this, but we still do not know when to start treatment actually. We don't know which treatment we should start, how to combine treatments, or should we combine treatments at all, how to address the problems with brain and eye, because many of these therapies were not tested for the brain amyloidosis. And also what is a huge problem is the access to these therapies in different countries, because these are really expensive therapies and patients in some countries cannot be treated with these drugs. I hope you can hear me now.
Perfect.
Okay, now we will go to our next patient. It is Tara. She's 23-year-old and she's a student. And in the last several weeks, she was complaining about some symptoms that appeared after her COVID infection. She had attacks of paresthesias in feet, lower legs, and hands, odd feelings in her joints, and reduced sweating. And her neurological finding was actually pretty normal. EKG showed only right bundle branch block, and her heart ultrasound actually showed a kind of mild restrictive cardiomyopathy, although patient didn't have any symptoms. Her laboratory was completely normal. This is her nerve conduction study. Basically, we saw some very mild carpal tunnel syndrome bilaterally and no other signs of polyneuropathy. So what we can say that our patient actually has, she has a small fiber polyneuropathy. It is a complex polyneuropathy because besides polyneuropathy, she also has cardiomyopathy, autonomic impairment, and bilateral carpal tunnel syndrome. So at that moment, I really didn't know what is her diagnosis. So I performed whole exome sequencing and I actually found mutation in heterozygous state in a GLA gene that is likely pathogenic and associated with Fabry disease. And then I saw my patient again and her mother, and I actually found angiokeratoma corporis diffusum in both mother and daughter. We tested the whole family and we found actually Fabry disease in patient's brother, mother, and grandmother. And we were able to offer them some kind of enzyme replacement therapy, and now all of them are on enzyme replacement therapy for Fabry disease. But I must say that all of these patients in Serbia actually are treated with a cardiologist, not at the neurologist. This is another patient, really interesting patient. It is Daria. She's 22 years old. And she previously had some back pain during ovulation. She is fatigable and irritable, but now she's coming to a neurologist with severe abdominal and back pain, vomiting, diarrhea, agitation, and confusion. And the next day, she developed upper limb weakness, sleepiness, then lower limb weakness, and she was admitted to the emergency center neurology department. And in her neurological examination, we found severe proximal and moderate distal weakness in both upper and lower limbs with absent muscle reflexes. She had tachycardia, and hypertension, and hyponatremia. So the diagnosis of acute polyradicular neuritis was made. We were thinking about proximal weakness, about hyponatremia that is seen in GBS, and also autonomic impairment. So she has a diagnosis of GBS at that moment. A nerve conduction study was performed. Her sensory nerves were completely normal, but her motor nerves were affected, and we can see a signs of axonal polyneuropathy, axonal motor polyneuropathy. But we had some red flags in our patient. Her personal history was with the red flag of the similar episode of abdominal pain and motor weakness that occurred 3 years ago. She was also admitted to emergency center. Then she also had hyponatremia with general tonic-clonic seizures. And the diagnosis then was made of a man, acute motor axonal neuropathy. So she was treated with IVIG and she fully recovered. But her family history is also with red flags. Her elder sister had episodes of abdominal pain and has fatigue. Her father is hospitalized in the psychiatric hospital, and her grandmother actually died in a psychiatric hospital. So we started to think about some other diseases in the differential diagnosis of GBS, and we started to think about complex polyneuropathies that affect also autonomic fibers with hyponatremia, psychiatric symptoms, and seizures. This neuropathy was motor, axonal, and recurrent. So we started to think about porphyria, and especially acute hepatic porphyrias. The most common of these is acute intermittent porphyria. And we tested our patients for the level of delta-aminolevulinic acid and porphobilinogen in urine, and these were really increased more than 4 times than the upper limit of normal. So we made the diagnosis in our patients of acute intermittent porphyria biochemically. Then we performed a gene analysis, and we found pathogenic mutation in HMBS gene that is associated actually with acute intermittent porphyria. So the diagnosis of acute intermittent porphyria was made, and how we can treat our patients with acute intermittent porphyria. We treat acute attacks with glucose overload or hematine in order to suppress the enzyme ALA synthetase. And we have chronic therapy. Previously, chronic therapy could be, for example, liver and kidney transplantation, or some patients were on hemin as a chronic therapy, which is off-label indication because of the complications that this therapy can produce. But now in the last several years, we actually have small interfering RNA therapy as a chronic therapy for acute hepatic porphyrias, which is givosiran. Of course, patients with acute hepatic porphyria should avoid inductors of ALA synthetase, and they should avoid certain types of food, drugs, alcohol, etc., in order to have less attacks of their disease. Givosiran, as I mentioned, is a new therapy, and VISION trial was a phase 3 trial that actually showed efficacy and safety of this drug. It was conducted on 89 patients with acute intermittent porphyria. And what was shown here actually is that the number of attacks was reduced for 74% in patients on givosiran in comparison to patients on placebo. And also a number of attack-free patients was 16% in placebo group and 50% in patients with givosiran. And those patients that had attacks still, they have milder attacks and a lower number of attacks. Besides this, givosiran was shown to reduce significantly levels of delta-aminolevulinic acid and porphobilinogen in urine. And this drug was approved for treatment of acute hepatic porphyrias, both in the United States and in EU. What we can see as a side effects of these drugs are anaphylactic reactions, some hepatotoxicity and nephrotoxicity, and also some patients may report fatigue, but fatigue is also part of the clinical phenotype of acute hepatic porphyrias. This is our next patient. His name is Mihailo, and Mihailo was born in a small Serbian enclave in Kosovo by consanguineous family, parents, and he has some neurodevelopmental problems. He started to walk at the age of 2. He had learning difficulties in school, and at the age of 9, he had a severe abdominal pain, and appendectomy was done. After that, he had frequent vomiting, diarrhea, abdominal pain, severe malnutrition. So at the pediatrician, cystic fibrosis was excluded. After, he had 2 another surgeries due to intestine obstructions, and he has a significant malnutrition. This is our patient at the age of 20. You cannot see here, but in his cranial nerves, he has bilateral ptosis, ophthalmoparesis, fascial muscle weakness, and sternocleidomastoid muscle weakness. Also, in his upper limbs, he have global atrophy and global reduction of strength, while in lower limbs, he has global muscle atrophy, excavated feet, and hammer toes, and he has a proximal strength being 4 and distal strength being 2 to 3 on MRC scale. A very, very severe phenotype. We performed a nerve conduction study, and we actually found polyneuropathy that was sensory motor and more demyelinating. As you can see, conduction velocity in median nerve was around 30 meters per second. And we also performed needle EMG, and we found myopathic pattern in both proximal and distal upper and lower limbs. So this patient actually had neuromyopathy. This is a very complex phenotype. Patient has sensorimotor demyelinating polyneuropathy that is associated with neurodevelopmental delay, gastrointestinal syndrome, and myopathy. And we were thinking about a kind of mitochondrial disorder because of this complex phenotype. And we actually found homozygous pathogenic mutation in the TIMP gene. TIMP actually encodes thymidine phosphorylase, which is important for the production of nucleotides in mitochondria. So impairment of this gene is leading to the mitochondrial DNA depletion syndrome that is in this case called mitochondrial neurogastrointestinal encephalomyopathy. And this phenotype is characterized by severe gastrointestinal and neurological problems. How we can treat this complex disorder? There are some anecdotal reports of patients that improved temporarily with erythrocyte thymidine phosphorylase, with peritoneal or hemodialysis, and with platelet infusions. And in some patients at the beginning of their disease, early during the disease course, we should start with a hematopoietic stem cell transplantation or liver transplantation in order to have a better course of the disease overall. At the end, I would like to say that previously, when you want to make a diagnosis of hereditary polyneuropathies, it was just an academic challenge. But now there is a reason also for patients to make a proper diagnosis, because this can define the therapy of our patients. Novel therapies actually for hereditary neuropathies appears on monthly basis, and neurologists should be aware of these therapies and also on clinical trials that are ongoing. So we can offer them a proper therapy. And what is also important, although we have a lot of new therapies that are really, really expensive, and the access of these therapies is not the same across different countries, especially in some parts of the world where these therapies are not available at all. At the end, I would like to thank you all. I would like to send you greetings from Belgrade. And this is our team that is dealing with the patients with hereditary polyneuropathies at the University of Belgrade. Thank you very much.
Thank you, Stojan. Wonderful walk through clinical findings and a very well explained rationale for the diagnosis and then for the treatment. I find this talk very inviting and with a great didactic value. And I hope that people attending will agree with me. I'm sure they will. As soon as you start talking, someone dropped an anonymous question on the chat saying or asking what are the most promising recent advancements in treatment of hereditary neuropathies. I consider that you have answered the question already, so I wouldn't start by that. And I would instead use what you've mentioned about the gene therapy for CMT1A to remind people of an historical fact that is the story of Jess Gelsinger. He was a guy in his 20s that in 25 years ago had a metabolic defect, so an enzyme in his liver that would cause increased ammonia bouts, and he was treated with gene therapy. Then we had much less knowledge about those techniques and probably even the AAV, the adenovirus cassette that was used to deliver the therapy has caused a very serious, unfortunately, so serious that the guy lost his life. So what I wanted to ask you about this is exactly how do you comment the fact that a gene therapy was considered for CMT1, and what kind of advice and what kind of comments that would leave you? What would you like to comment about that? Do you think that CMT1 is a low-hanging fruit for gene therapy in neuropathies, hereditary neuropathies? Do you think probably you have a better candidate for that?
Yeah, I believe we should start maybe with the more severe diseases. But anyway, when we learn new things, how to deliver gene therapy and how to decrease the number of targets of gene therapy, I also think that this will be a perfect solution for all these types of hereditary neuropathies, probably in the near future, because we learned a lot of lectures from other diseases, for example, with the SMA, for instance. So I believe this is the future and very near future.
Excellent. So positive tone, and I would agree that is the case. We start seeing that not only the traditional delivery of genes through cassettes, but other techniques like CRISPR-Cas, etc., are making way into a lot of conditions. And the other thing that I found interesting is that in your talk, you give an example of a successful repurposing of drugs, and more than that, the use of combination of existing drugs to treat those some conditions that were untreated until then. So do you see any other examples besides the one that you gave that would be, in your view, candidates for that, or not?
Yeah, I think there will be more and more, and that artificial intelligence will help us a lot here, because artificial intelligence can better search for all of this information and maybe give some suggestions and then try. But for example, also we have some repurposing in muscular diseases like in myotonic dystrophy. It seems like metformin can be useful, for example, in patients with myotonic dystrophy type 1 and 2, and also some other examples. So I believe this is interesting. I do not believe that these drugs can really save the phenotype and restore fully the phenotype, but maybe they can slow the disease course, and in combination with some other drugs can help, especially because with these old small molecules, we know how to deal with, we know their side effects, and it's easier with us. We have experience with these drugs.
Yes, quite right. And that's important, namely for the diseases that have less severe phenotypes, because that would be more challenging. And you talked about a disease that I know about a bit because I'm Portuguese. So Val 30 Mets has been in my radar since I was a trainee many years ago, and I've witnessed the suffering of those patients. And so one of the things that you mentioned is gastrointestinal and other autonomic dysfunction symptoms. And is that also a good, do they have a good response to the treatments you've indicated, or is it more selective? Do you have any preference regarding those kind of symptoms?
Yeah, regarding these symptoms, they have never been measured in clinical trials as important outcome measure. So mostly it is focused on cardiomyopathy and polyneuropathy symptoms. So this is not properly investigated. What I know here in Serbia, we at the moment we only have tafamidis so far. And what I see is that the effect on these diarrheas that are severe in our patients are not so good. So these patients still have diarrheas. But unfortunately, I do not know what is the case with these new therapies like small interfering RNA or antisense oligonucleotides and how they affect these problems. I believe if you start on time, that this can probably help also with these symptoms. Well, I don't know
Yeah.
what is your experience because you have more patients.
No, yeah, in Portugal, in fact, I would have to ask Isabel Conceição or someone that I know there, or Teresa Coelho, for that information. But I don't think that they report much improvement, unfortunately, or at least the improvement on other target organs is probably more important to save patients' life. But as you imagine, the quality of life of those patients regarding hypotensions, orthostatic hypotension, and diarrheas is much affected by the disease. And that's why I was wondering what was your impression about that.
One
So,
of the patient is traveling 300 kilometers for checkups at my outpatient unit, and he has to stop for 3 or 4 times to have a stool somewhere because he's really suffering because of this, and he's really young. So this is a true problem for these patients.
yes, indeed, indeed. And I've witnessed that personally, and I hope that that side of the symptomatology is addressed very soon by the therapeutics. I hope so.
So hope so.
So I think we've reached our time, and I would like to thank you very much for this masterly display of clinical expertise and for your hopeful message for us that see patients, and mainly for patients, I think, with these conditions. And I'm sure we will have a very good and soon opportunity to talk again and to profit from your knowledge and expertise. Thank you very much, Stojan.
Thank you very much for your invitation. I really enjoyed.
Thank you. Bye. Bye
Bye.
to all. And don't forget to leave your feedback on the link that is present on the chat. Thank you. Bye.